It's UofL Today on 93.9 The Phil. Here's your host, Mark Hebert.
And welcome to UofL Today with Mark Hebert. Glad you're joining us. We'd also like to welcome our viewers on Metro TV, the City of Louisville's local government access channel. Glad you're joining us. Thanks to Mayor Fisher and his gang for putting UofL Today with Mark Hebert on Metro TV. So we're going to be talking about all the great things that are going on at the University of Louisville. That's what we talk about on this show. We're talking about groundbreaking research, community involvement, outstanding students, cool events. Hopefully you'll learn something today, and assuming you're a UofL fan or supporter, you'll have something to brag about your school. So one of the topics we're going to talk about today is social media and texting. The way many of us communicate today instead of talking. Technology may have revolutionized the way most of us communicate, and it's also revolutionized the way children and young adults with special needs are communicating. According to a UofL researcher, we will be talking to him. His name is Rob Pennington, and he also moonlights as a rock and roller and a punk rocker, so we'll ask him about that. And kids with cancer, it always breaks our hearts when we see it, especially when a child suffers a relapse of cancer. Well, Dr. Kenneth Lucas is doing research on a vaccine that may help prevent relapses of some childhood cancers, and he'll be on the show. But first, if you're in my age bracket, the 50s, you've probably broken some bones, you got bad knees, you're looking at hip replacement at some point. Well, UofL has an orthopedic bioengineering lab that's looking for new and better ways to help heal those injuries and put us all back together. Mike Vore heads up that lab and has a new product of his own on the market. And welcome, Mike. Glad you're here. Appreciate it.
Glad to be here.
All right. Well, tell us about what is the UofL Orthopedic Bioengineering Lab. It's a big title. What does it mean? What is it?
It's a mouthful. Well, I came to Louisville in 1992, and about that time there was a large explosion in the technology available to surgeons. And so it made sense then for the orthopedic surgeons at UofL to develop an orthopedic laboratory where the surgeons could work together with a biomedical engineer to look at the new techniques, to look at the new technology, and really evaluate it and decide what worked and what worked best. And then as a bonus, we get to design new things as well and come up with new products and new surgical procedures.
All right. Well, let's expand on that a little bit. So is this a case where you take products that are already on the market, generally speaking, by some other company, and you say, well, let's try this thing out, see if it works? Is that what the bioengineering lab does?
That's mostly what we did for the first 10 years or so. So the surgeons will have a new product that comes on the market, and
such as what?
Well, such as a new plating system for fixing fractures.
Okay.
So in the past 15 years, plating has evolved a little bit. It used to be just a simple plate with holes in it, and screws would go through the plate and into the bone. New materials have come out. They've evolved from stainless steel to titanium. Lately, the screws now lock into the plate, so it's a much more stable construct. So the surgeons will come to me and they'll say, is this really going to be better for fixing a fracture? So we can go into the laboratory. We can use cadaver bone, or we can use synthetic bones, or maybe animal tissue. Mm-hmm. And we set up in a servo-hydraulic testing laboratory machine physiologic loads. And so we replicate what kind of loading these products are going to go through in the patient.
How much pressure you put on your leg,
right? Yeah,
something like that.
Walking on it for a million cycles, and is it going to break? Is it going to hold up? Because bones will heal best when they're stable and not moving around too much. So we can measure that very accurately, and then I go back and we've published a lot of articles with spine surgeons with new technology in the spine, orthopedic trauma for fixing fractures, sports medicine, total joint replacement. I've done a lot of work with all the surgeons at UofL, and over time I became even more fascinated in bone itself as an engineering material, because we get to play with all kinds of great materials, titanium, stainless steel. They've got great instruments in the operating room, but to me, bone is an even more fascinating material. If you think about a material that can totally heal itself, and bone is one of the few tissues in the body that doesn't scar. Over time, bone actually becomes completely normal again, because the cells in the bone are constantly working to repair and to remodel the bone back to a normal condition. So imagine an engineering material that's constantly monitoring itself and making changes to where if it's overstressed, it actually gets stronger, it gets larger. That's what our bones do throughout our lifetime. So I still work with the surgeons on studying new orthopedic surgery techniques and new devices that come out. But when I get into doing research and actually going out and looking for research funding, the work I do more on a basic science nature is about bone and osteoporosis and healing bone and making bone as an engineering material a better product and better understanding of it for the patient.
Right, and you've come up with something. I guess it's your own device that you came up with. You patented this thing, I guess?
Right, we did.
Well, what is it? Why don't you
recently.
show us what that
Sure.
is? And,
Right.
Well, for a radio audience, they're not going to be able to see it.
Right.
For those of you on Metro TV, you'll probably be able to see this.
All right, well, this is a product. It's a bone graft substitute product. A little bit of background. Bone grafts are used in about half of all orthopedic surgery procedures because there's damage to the bone. There may be a void that needs to be filled. Sure, they use plates and screws and other titanium devices, but sometimes biologically you've got to restore that lost bone and get it to heal and turn back into viable bone over time. Most of the time that bone graft is taken from one part of the body and put in another place, and it heals very well. But there are some synthetic materials, believe it or not. You can create a formulation of calcium phosphate, and it will harden into the very mineral that makes our bones hard. So it's the same mineral substance that makes up bone.
It's synthetic bone.
It's synthetic bone, it is. And the body will actually see that and recognize it as bone. The cells of the body will slowly resorb it and replace it with living bone tissue over time.
So this would be used, this is what, a graft?
Yeah, so this is a synthetic graft. What it is it's a cement. Imagine like a silly putty or a Play-Doh that the surgeon can mold into any shape, stuff it into the defect in the skeleton, pack it in there. It will harden in place so it provides mechanical stability. And then over time, the body's cells will come in, gradually resorb and replace it. The body's cells are actually doing that all over our skeleton at all times, resorbing bone and replacing it. That's why our bones don't fatigue and break. So it turns into live bone after a period of time.
So would this be used in every single kind of bone graft that we'd use, or only in certain like legs or femurs, or I don't know, you tell me.
Well, right. So the most common use for a product like this is in orthopedic trauma. So you've gotten a fracture. Say you're a little older, you're a little unstable, you fall down, you break your wrist. Well, the bone around your wrist gets compressed, and when the surgeon restores that bone to its normal shape, there may be a void in there that needs to be filled with something. You can opt for a product that is totally biologic, that has no mechanical stability, and you have to use a lot of plates and screws to hold everything in place while it heals and turns back into viable bone. Or you can use something that's very mechanically stable. And some of the problems with those products is that they didn't resorb and remodel into live bone fast enough. So that's really the invention we came up with, was a way to process real bone graft. We get bone from cadavers and we process it in our facility, and we add it to this calcium phosphate cement product. And the combination of these two products is both strong and stable, and so it will support the bone while it's healing. And then it has bone mixed throughout that the body will really replace fast and turn into live bone over time.
What else are you working on in the Orthopedic Bioengineering Lab, and is it anything with the Speed School of Engineering?
Oh, that's a great question. I actually have a joint appointment. I'm half in the Department of Orthopedic Surgery at the medical school, and I'm half in the Department of Bioengineering at Speed School. And I have, I think, about 6 graduate students right now from the engineering school working in my lab, because what I do at its core is truly engineering work, and you have to understand the physics and the math behind the work we're doing. We're doing some projects. Like I said before, my real passion is bone as an engineering material and osteoporosis. And what I want to do is prevent fractures from happening before they happen, because as we age, our body adapts. Like I was saying earlier, it senses the mechanical environment, and it works. If we exercise a lot, our bones get stronger. But the negative is if we're an astronaut and we go into space and our skeleton isn't loaded, the body's going to resorb that bone, and the skeleton actually gets weaker. Right. And when we get older, our body becomes more and more specialized to the types of loading that we place on it. We aren't as active. So in particular at the hip, the bone gets weaker very quickly. And when we fall, we can break our hip, and hip fractures are devastating to society. A lot of people don't survive having a hip fracture.
So you're working on all those things.
So we're working on that. We're actually, we had cadaver femurs in the lab this week, and we were placing strain gauges on them. We were loading them We were measuring how much strain was going through there. The engineering students are really having a
and your students are having a good time doing that, I'm sure. All right, Mike Vore from the Orthopedic Bioengineering Lab at the University of Louisville. Thanks for coming on. We appreciate it.
Thanks for having me.
All right, when we come back, social media and writing skills, its impact on people with special needs. You're listening to UofL Today with Mark Hebert on 93.9 The Ville.
My name's Natalie. I'm a junior studying communications at the University of Louisville. UofL has given me mentorship opportunities. I'm in the honors program. I've had a lot of opportunities through that. I got involved in Greek life. I'm a Cardinal ambassador, so I get to show people what I love about our university. And then I'm also on the student orientation staff, so I get to work with the incoming freshmen and calm any of their nerves about college, and just show them my passion for UofL and hopefully transfer that to them. Family is really what it's all about here at UofL. Go Cards!
And welcome back to UofL Today with Mark Hebert. We've got a rock and roller with us right now, but his day job, he's a special education professor in the College of Education and Human Development. His name is Rob Pennington, and he's been doing some research on the impact of technology, social media, and texting on people with special needs, as well as on written expression by children with autism. So welcome, Rob. Thanks for coming on the program. I appreciate it.
Glad to be here. Thanks, Mark.
I'm glad you're here. All right, well, let's talk a little bit about what your specialty is, working with kids with special needs and trying to help them learn and communicate. So talk a little bit about that.
Sure. So I started as actually a special ed teacher here in Jefferson County. I went to our competitor there, University of Kentucky, which
Well, we'll forgive you. Hopefully you learned something
I have some
there.
purple blood.
Yeah.
I got some purple blood. I got my PhD work there. I've always worked with kids with more severe disabilities, and so kids that usually have problems with communication, sometimes have challenging behavior, have difficulties acquiring new skills. And so one of the areas that I focus on has been helping these individuals develop a stronger communication repertoire so they can have some control of their environment by asking for what they need, but I also work in the area of written expression, which is a kind of a small area in the research field. A lot of folks haven't kind of tapped into that as an area of research, as an area of skills that need to be developed in this population.
When you're talking about written expression, of course, I'm looking at writing down something on a piece of paper. Is that what the norm would be for a child with autism or some disability like that?
Well, certainly for some, but we also use technology. So whereas you might write a sentence, I see a little duck, a child with a developmental disability, we may train them to make selections on a computer screen of whole words. So that way they don't have to develop all the spelling skills. They don't have to have all of some of the basic literacy structures, but they're able to communicate a clear message.
And so I assume there are pads or something that their parents use and that the children use to communicate mainly with their parents, I assume?
There's a range of technologies available now. We used computer desktops, but now on the iPad, there's all sorts of great software available.
So technology has been good with kids with for kids with special needs.
That's great. I mean, the challenge with that is moving forward. Again, there's a new app every day, and so they develop quicker than we can conduct research using them. But yeah, it's been really helpful.
We're talking with Rob Pennington, who's with the College of Education and Human Development at the University of Louisville. So do you teach classes as well?
I do.
All right. So the students that are coming through, what are you teaching them?
Sure. So we're teaching them kind of the whole package and working with this population. So we're giving them a strong foundation, what we call applied behavior analysis. So that's really how kids learn and why they engage in certain behaviors. Then we also teach them some of the evidence-based practices in instruction. We make sure they have a broad depth of curriculum. And so the idea of curriculum for persons with more severe disabilities has really changed over time. Again, when folks were first moved out of institutions, we really just focused on functional life skills. But now there's expectation with the beginning of IDEA and then No Child Left Behind that all kids have access to core content. So we have some really great expertise in our department on how to teach core content to kids with more severe disabilities.
So the bar has been raised.
Definitely. And you know what? And our kids are rising to it.
When you say our kids that have the disabilities or our kids that are going through wanting to be special ed teachers, or both?
Both, definitely. But yeah, definitely the population of kids with disabilities, they're acquiring more skills than we ever perceived they could.
And what are you finding as far as the students who show up at the University of Louisville who want to be special ed teachers? Are they any different, or do they have to have a different skill set than the teachers in past years?
So two different questions there.
Okay.
The first question is yeah, they are different in special ed because so we interview. We have a dual certification program at the bachelor's level, and so what we do is we get folks that come and want to be teachers of kids with moderate and severe disabilities, and 90% of the time it is because, not because they've come from another field or not because somebody said, hey, this is a good idea. It's because they've been a peer tutor, so they've worked with these kids in their high school setting, or they have a family member, so they're really passionate about this. Your second question is, do they have to have different skills? Yeah, definitely. There is a whole set of, as I mentioned before, evidence-based practices that are different than what general education teachers. And theoretically, or not theoretically, but that's also a problem because now there's more expectations for general ed teachers to serve kids with disabilities in their classrooms, but they may not be getting all these evidence-based practices.
And they may not have had the training and the skill set if they became teachers 20 years ago.
Right, definitely.
And is there any program to help train, you have in-service days and those kinds of things for teachers that are now in the classroom? Are there any programs at the University of Louisville that you're aware of to try and help them get better skills as they go forward?
Yeah, we have a great relationship with our Kentucky Autism Training Center, and our Kentucky Autism Training Center works throughout the state working with in-service teachers and developing their programs. So there's an application process. They're like, hey, we need help. And so these folks will go out and actually do coaching, which is much better than the old idea of sit and get training. Here, watch this video. This will make you better, or come hear me talk. Now we know that the data are fairly clear that to move teachers' practice forward, you've got to work with them in their classroom.
And some of the research that you've done is based on social media. What was that? What were you trying to figure out with social media and kids with special needs?
Definitely. So we did a bunch. So my first research studies involved working with young kids with intellectual disabilities and autism, and we were teaching them to use technology to write simple stories. Well, I was approached by kids at different levels, and story writing is a skill that kids learn at a really young age. And so to work with a 19-year-old on here's how to write a very simple story, there might be other more relevant skills. So a teacher came to me and said, hey, I want to work on writing. And so we said, well, what writing is most germane to this population? And we have a program here on campus where it's a Jefferson County program where kids with severe disabilities or moderate severe disabilities attend classes. And this teacher and the teacher said, hey, these guys are looking around at everybody text messaging, and that's what they want to do. So we partnered with the engineering school, Carla Welch and Nasser Sadatsi, and we actually used a robot to teach the kids in the class to write text messages that were appropriate. So I asked one of my undergraduate classes, I said, hey guys, what would be an appropriate text message? And they developed here are 3 components that should be in there. And then we used this robot to actually teach kids in the classroom to write appropriate text messages.
So could these special ed students, could they pick up that and do that?
Oh yeah, it was perfect. And the paper became published in a Journal of Special Education Technology.
So using text messaging to help these kids communicate, basically.
Right. You know what? Guess
Did it
what?
work, or was it more difficult because it's becoming less and less an audio world where we're talking to each other and more a world where we're texting each other? Is that hurting the opportunities for kids with special needs and autism to communicate, or is it helping?
So that's a great question. And what we say is we don't know yet. We say, well, that's an empirical question. But the reality is that if that helps build on the rationale why you would teach writing to this population. I was once approached by a very famous researcher, and he goes, oh, pretty cool study early in my career. He goes, but why are you doing this? Isn't there other more important things in writing? But the reality is that if kids can't put simple sentences together, if kids can't construct simple communicative messages using social media, they're going to be missing all these opportunities. Because I mean, you look out the window here and there's kids walking down texting to communicate, and so these kids struggle enough as it is to be a part of good social networks. And so we want to make sure they have the skills to participate in this opportunity to learn social skills.
All right, last question before we go here.
Yes,
you've got a secret life. Tell us about the secret life of Walter Mitty, or in this case, Rob Pennington. What do you do on the side?
People joke about it. I've been playing in bands in Louisville since 1985. And so actually this summer I went on a European tour and toured over there. But I play in a whole series of bands. It's very consistent with what I do. We're a very kind of socio-political punk band. I think this really falls into working with some disenfranchised folks. So I love it. And kids every now and then will Google me, and they're like, wait a minute, this guy's teaching me how to graph, and he also is screaming in a rock band. So it's pretty fun.
All right. Rob Pennington, the cool professor at the College of Education and Human Development at the University of Louisville. Thanks for being on, Rob. Appreciate it.
All right. Thank you, sir.
All right. When we come back, trying to stop cancer from coming back in kids. You're listening to UofL Today with Mark Hebert on 93.9 The Bill.
This is our time to soar. We are an unstoppable force of innovation and academic excellence, solving the world's mysteries through research, stimulating growth in our community and beyond, and inspiring the next generation of leaders to build a better future for all of us. We are the University of Louisville. Watch us take flight.
And welcome back to UofL Today with Mark Hebert. Too often we hear heartbreaking stories of children who seemingly have beaten their cancer only to have it return. Well, the University of Louisville's Dr. Kenneth Lucas from the Department of Pediatrics is working on that problem. We're trying to work on that problem,
That's
right? Dr. Lucas, welcome.
Thank you very much. Thanks for the invitation to talk about our exciting new trial.
All right. Well, let's talk about the trial. Well, first off, I guess, what do you do in the Department of Pediatrics?
I'm the director of pediatric hematology, oncology, and bone marrow transplant. Basically, take care of kids with blood and cancer disorders.
Okay. And so as part of that job, you do some research.
We do, and particularly a vexing problem is what to do, like you mentioned, when kids' cancer comes back. So that really got us to thinking about how we could potentially use the immune system to help prevent the cancer from coming back, and we developed this vaccine trial.
Okay, so what's the vaccine intended to do, and what are you trying to figure out?
Well, like anything that you're trying for the first time, you really want to try it in a small scope where things can be analyzed very closely in a narrow group of patients. So we're choosing patients that have relapsed. They've had their cancer come back. We've hopefully been able to shrink their disease down with chemotherapy, and we'd like to keep their cancer away permanently by giving a vaccine, which we grow from their own blood cells. So these patients come frequently from other centers halfway across the country to have their blood cells collected. We make their blood cells into cells that can present cancer proteins to their immune system. We give a chemotherapy drug in very low doses before their cancer vaccine that makes the cancer cells more amenable or more likely to be killed by the immune cells that get stimulated by this vaccine. So it's a combination, referred to it as chemoimmunotherapy. So chemotherapy first, make those cancer cells more susceptible to being killed, and then we give the vaccine and hope that immune responses are developed after the vaccine.
What age of children are we talking about here? Are we talking about little kids or teenagers?
Little kids, teenagers, all comers. So 2 to roughly age 30 will take patients. Most of them are little kids, some teenagers.
And have you started the trial yet? Is it already in
it's in motion. It's been in process for about 3 years now.
Okay, and so how long might it take before you go through the whole trial? I know it takes forever to get something to market.
It does take a while. The purpose of the phase 1-2 trial is to make sure it's safe. And so the next step is to look at your data, see what outcomes are, see how the patients have done, see if they've tolerated it, and more importantly, to look at seeing whether we're getting an immune response to this vaccine. And so that's taking it back to the lab, taking those patients' blood specimens back to the lab, and seeing can we indicate that they actually did have an immune response? And if so, how can we boost that better? So our second step of this vaccine study has actually been adding a vaccine helper called an adjuvant. So it's a helping drug that helps stimulate an immune response from the body's immune system. So to answer your question, probably another year or two with the vaccine study, then we'll be going on to our next generation of studies based on analysis of that data.
And if it works, presumably you're talking, 5, 6, 7 years before you can get it to market, or is it longer than that? Or
it could be longer than that. The next stage could be a phase 2 trial in a more refined group of patients. For example, patients who are at very high risk for relapse but have not relapsed yet. That's a good target population.
All right, we're talking to Dr. Kenneth Lucas from the University of Louisville, Department of Pediatrics, and we're talking about a clinical trial of a vaccine that may help keep cancer from coming back in kids. What kinds of cancers might you be targeting here? I mean, is it a wide, right now, since it's early, is it every kind of cancer you're hoping to keep in remission, or what? You tell me.
Not every type of cancer. So we pinpoint neuroblastoma, which is the most common solid tumor. It's the most common solid tumor in kids outside of brain tumors being the most common type of solid tumor. So it's generally affects organs in the abdomen, chest, and about half the time it can be fatal. So there's obviously a lot of patients with this diagnosis that are at high risk for having their disease come back or have had it relapse. Other diagnoses, bone tumors, things called sarcomas, are also included. We also have a very similar study that we're doing exclusively in brain tumor patients. So the same type of chemotherapy, vaccine backbone we use with brain tumor patients.
Well, right now, what are the odds that a cancer will come back in a child, that they're not in remission? What is the percentage? I don't know.
That's a great question because there's so many different types of cancers, as you have alluded to.
Let's talk about the ones that you just talked about.
The most common type being pediatric leukemia, ALL, we cure 85% of the time. But for the types that we're focusing on, neuroblastoma, stage 4, neuroblastoma meaning it's spread outside of its primary site, it's got an over 50% chance of coming back. Wow. And when it does, there's not a lot of options for cure, as is the case with some of these sarcomas when they come back and they've spread. Many times these tumors are resistant to chemotherapy, they're resistant to radiation, and doing so that just adds a lot of toxicity to the kid without really affecting long-term outcome. So that's why us and some other centers are looking for, just how can we harness the immune system to
so to be blunt, if it comes back in a child in these particular types of cancers that you're looking at, if it comes back, chances are really good that the child's going to die.
That's correct. Unfortunately, they have a very high risk of not doing well long term. Yep.
And this vaccine, if it works, would it block the cancer from coming back? I mean, it's coming, as I understand it. Again, you're talking to a communications major here, not a doctor. Okay. So as I understand it, though, if you can get their own cells or their own blood to it develops that immune system in that patient, correct? That's basically how it works?
Correct. We want the patient's immune system to start fighting the cancer, and there's several different mechanisms whereby the tumor outsmarts our immune system. We want to outsmart the tumor before it has a chance to outsmart the immune system. So ideally, when you identify a patient that's high risk to relapse in the future, say 5 or 10 years down the line, you could give something to stimulate their immune system against their cancer to help prevent it from coming back. So you're not in the situation where it's come back and we don't know what to do.
What do you tell parents when they come in and they say, my child's back with this cancer? What hope can you give them, or what's the frank conversation that you have with them?
We can't give them any certainly false hope, or so we have to be very realistic. It's a phase 1 trial. We don't know if this will help. It's our intention to help, and we have some data in the laboratory that suggests it could help, but we don't know. And we're just trying to collect information, and we hope that it does help your child. And if it's not helping your child, you're going to be the first person to know, so we can try to find something else.
Okay. Well, what's next? What's next on the horizon here trying to battle these childhood cancers?
The next step is if we find out that the vaccine needs some work, is to add helping agents to the vaccine. There's a number of antibodies that are out there that are used in adults, especially with lung cancer and a tumor called melanoma, a common skin cancer, that can be used in conjunction with a vaccine to help even boost the immune system all the more. The other possibility is taking blood from these children and actually growing the tumor-killing cells themselves, rather than the cells that are going to stimulate the immune response, and putting those back into the patient. So those are both options we're looking at.
And that's all happening at UofL?
Yes.
Well, that's pretty impressive.
Well, thank you.
At least we think it is. We hope it works, right?
We sure do, and we really appreciate the support we've had from things like Raise Red. I don't know if anyone in the audience is familiar about Raise Red. It's now in its second year. They raise money exclusively for pediatric cancer and for kids with blood disorders. It supports our clinic, and it also supports this research effort.
And so you've got University of Louisville students raising money for your projects.
They are dancing and canning and raising money for this stuff, yes.
And as I recall, didn't they raise something like $150,000? Like, it was some big number
in the first year. The second year, they raised $226,000.
Wow.
And so we hope that this just continues to grow.
So kudos to the University of Louisville
Absolutely.
students.
They're amazing.
And that's great. And it gets them involved in what's going on down at University of Louisville.
Absolutely. They get down to our clinic. They meet our patients. They come to our laboratory. They see where we grow the vaccine, and it really gets them pumped, because they can see directly where these funds are going, and it all goes directly to the care of our children.
Right, and so there's a good pitch for if you're thinking about coming to UofL, you get a chance to, if you're an undergrad,
you get an opportunity to dance for Raise Red.
There you go, and work downtown at the Health Sciences campus on these types of problems. One last question: these children that are coming in from, I assume they come in from all over the United States for this trial. Do they have to come to Louisville for for the trial?
They do have to come to Louisville. We do let them go home for checkup visits and stuff, but because the way FDA regulates it, they need to get most of the study here.
Okay. Dr. Kenneth Lucas, appreciate it.
Thank you. My pleasure.
Hey, good luck. Good luck with the study. Hope it works.
Thank you very much.
All right. So if you missed this program or want to catch the podcast of any other UofL Today with Mark Hebert program, you can find them at soundcloud.com/UofL. And many of our programs are also on YouTube now. So thanks for listening to UofL Today with Mark Hebert, and go Cards.